Welcome to the Friends of NPACE podcast, brought to you by Haleon. As a leading global consumer healthcare company, Haleon is dedicated to delivering better everyday health with humanity. Known for trusted brands like Advil, Excedrin, and Voltaren, Haleon leverages science, innovation, and human understanding. Haleon is proud to collaborate with NPACE to educate healthcare professionals about our pain portfolio and the latest healthcare information. For more information, visit www.haleonhealthpartners.com.
So let's talk about the basic medicines. So let's talk about, before we even get to this question, we all know that 5 ASAs, and you can see the names underneath there, there's several names, are useful in mild to moderate ulcerative colitis, But clinicians are also using them in Crohn's ileitis, And are they very effective? So here's the answer. Here we go. Use is controversial. Studies have shown only a modest benefit in Crohn's ileocolitis and those patients who prefer to avoid steroids. So again, we know that the 5 ASAs that we just talked about, useful in ulcerative colitis, Crohn's colitis, but controversial use in Crohn's ileitis. Many of my colleagues still do it, but I want you to be aware of why that is, because they don't want to move on to steroids or more complicated medications. Does QD dosing really matter in 5 ASAs? Remember, many of them require several doses a day. Does QD dosing really matter? Here's the interactive question, and here's the interactive response. Less pill burden. So pill burden is the amount of pills that we have to take in a day. And again, we all know that the fewer pills that we have to take in a day, fewer capsules, fewer pills, the more compliant the patient will be. So I just want to reflect on some side effects of 5 ASAs. We don't think about that very often, but again, they do exist, and I want to bring it to your attention. There can be headaches, there can be rash and photosensitivity, and there can be decreased creatinine clearance. I remember a few years ago, somebody asked, how often should we be doing a creatinine clearance? And it's not in any particular guidelines. I would say probably once a year, once every 2 years for those patients who are on chronic 5 ASAs. Let's talk about this, antibiotics and Crohn's disease. And there is a niche use for antibiotics and Crohn's disease, and it's useful in patients with active colonic and perianal Crohn's disease. Steroids, dose, duration, and trick of the taper. So this is going to be something useful in gastroenterology, as well as something that you can use in general medicine as well, because there's some tricks that I wanted to tell you about that are going to be particularly helpful. So let's get right into it. So here's our interactive question. So when we're talking about inflammatory bowel disease, is there any benefit of giving more than 60 milligrams of prednisone or prednisone equivalent to an IBD patient? What do you think that answer is? And the answer is no. And the real key here is beyond 60 milligrams, we're going to get steroid side effects without benefit whatsoever. So here's what we need to know about the steroids. Steroid dose, usually it's going to be prednisone 40 to 60 milligrams. We taper after response. We can discontinue, we slowly taper it down, and we discontinue it after 1 to 2 months. And we're getting away from steroids, and we're going to talk about that in just a moment of why we're getting away from steroids. We had alluded to that previously, and I want to make sure that you're all aware of that. It's the steroid side effects. The steroid side effects, plus the fact that steroids just make the symptoms improve without really taking care of the disease itself. So that's what we have to be aware of. This is one of the tricks that I want to share with you. And all of you have had, I'm sure, similar experience. And I remember many years ago, a patient told me of 1 milligram prednisone tablets. Here it is. I wasn't aware of that until that patient told me about it. Because again, at up to that point, I was saying divide that 5 milligram into half and half. But sometimes we need to do a slower taper, and that really makes a big difference with regard to some of the patients. I want to share with you that bit of information today. So re-emphasizing the risks of steroids. Here it is in Crohn's disease. Failure to achieve mucosal healing. This allows for stricture formation, high relapse after withdrawal, and steroid use and cardiovascular complications, as well as the myriad of other complications that we are aware of. And IBD patients on steroids, and what are the risks? And the risks are, here we go, impairment of wound healing, increased post-op infections, and 7 times greater anastomotic leaks if surgery is needed. Wow. Very important. So this is one of the most important things that we're going to be talking about today. And this is a similar kind of situation in ulcerative colitis, but we're going to concentrate here on Crohn's disease. Look at this graph and look at the left side. This is months since the inflammation has been detected. So months proceeding. And then over here, we see the different elements of what happens in Crohn's disease. There's large amount of inflammation. There's some stricturing and some penetration or fistula formation. And there we go. So in the beginning, it's a large amount of inflammation, a tiny amount of stricturing, and some penetration. But the real key, as time goes by, less inflammation, more stricturing, and a lot more penetration. So this reflects on something that we just talked about in the very beginning of this lecture. The earlier you catch this process, the better off the patient will be. Remember that long stricture that we had seen earlier? That long stricture, and I said that that patient inevitably will need surgery. That's when this happens, when a patient is continuously put on steroids, or the diagnosis is misconstrued, and that's how we get into trouble. So the real key here is catch it as early as possible. So use of non-systemic steroids in Crohn's disease. And here we see an example. It's called budesonide. Why do we use them, and what's the effectiveness? So budesonide can be used in Crohn's disease. And why do we use them, and what's the effectiveness? This is an interactive question, and let's see what the answer will be. There are fewer side effects. And the other thing is, even though there are fewer side effects, it is less effective. It is about 40% less effective than prednisone. That's the big problem that we're dealing with when using budesonide. Let's now talk about antimetabolites and see what we need to know about antimetabolites. And this area has also changed. So I want to just kind of bring you up to date with regard to what has changed with antimetabolites in the year 2025. And the names, as you can see, azathioprine, 6-mercaptopurine, and methotrexate. We'll talk about the risks and the benefits and how they're used in 2025. So the risks and benefits are there can be immunocompromise. There can be a cause for lymphoma, mostly non-Hodgkin's. Lymphoma is directly related to the duration of therapy. So we need to be concerned about that. And how are they used in 2025? They're used in addition to anti-tumor necrosis factors, and we're going to talk about some of the tumor necrosis factors in a few moments, in order to prevent immunogenicity and to bolster response. So it's a combination that we use. There were years gone by that we used to use antimetabolites in and of themselves. But again, look at the risks. It's that lymphoma risk. And we don't want to do that. We just want to use the minimum amount of antimetabolites that we can to prevent immunogenicity. Look at this. This is really important. So the use of antimetabolites, we already have said, increases the risk of lymphoma and cancer. Those patients over 65 are particularly vulnerable. Lymphoma and cancer risk is related to the duration of the antimetabolite, but most importantly, stopping the antimetabolite reduces the risk to 0. Stopping it reduces the risk to 0. Here are some of the anti-TNFs. You've heard the names before. You've heard the name infliximab, adalimumab, certolizumab, and golimumab. They're out there. They've been out there for over 20 years. And let's talk about what we know and what we need to still figure out about all of these medicines. The indications are moderate to severe inflammatory bowel disease. The benefit, they do work quite well. But there are risks of the anti-TNFs: congestive heart failure, non-melanoma skin cancer, infections, TB. And again, one of the things I want to just re-emphasize for all of us is that when we're looking for the possibility of TB, skin testing, we can still use skin testing, but many of us are using quantiferon gold, a blood test, to make that determination. There can also be the potential of fungal infections, hepatitis B and C. So lots of infections, lots of concern with regard to the anti-TNFs. And again, we'll talk about some of the other medicines in the newer generations that have fewer side effects. But again, they may not be as effective for some of our patients. That's the key. And we'll talk about that in just a little bit. Okay, let's look at this. Anti-TNF limitations in Crohn's disease. 70% respond, 30% do not respond, which is called a primary non-response. And that's been part of the difficulty as well. That's been part of the difficulty as well with regard to looking at some of the other kinds of newer medicines. Can we get a better response? And sometimes we can and sometimes not. Look at this other thing at the bottom. 50% of patients lose response over 1 year. That's called a secondary non-response. And that's when the antimetabolites play a large role. Using the anti-TNFs and the antimetabolites to a large degree prevents this from happening. It's still going to happen, but it's going to reduce that significantly. That's when we use the antimetabolites. So what do we need to know in primary care? So let's get back to what you need to know, because there's certain things that are extremely important. IBD patients do not receive adequate preventive services. Why does that happen? Who's in charge? GI or primary care? We assume you're going to do the vaccinations. You assume we're going to do the vaccinations. And we both know it's going to be CVS or Walgreens that are going to be doing the vaccinations. Somebody's got to write the orders. And we'll talk about what vaccinations are important. We need to screen for osteoporosis, not only for patients who are on steroids, but for patients in general who have Crohn's disease, because again, Crohn's disease in and of itself can decrease calcium absorption. We need to do cancer screening. We talked a little bit before about immunomodulators, and that can cause cancers, as we've said. We need to screen for depression. You're probably going to see these patients much more frequently than we as gastroenterologists. How are they doing? How are they feeling? Are they having depression? It's not unusual at all to have depression. Oh, look at this. We're coming back to smoking cessation. Wow, we talked about that before, and now you understand how important it is. Okay, you'll be able to look at this because, again, it's really important that we have this health maintenance checkup for adult IBD patients. So this is an opportunity to coordinate with a gastroenterology office. Why is this so important? It is so important because especially the preventable diseases, we want to get this into the patient as soon as possible to prevent further things from happening at a later time. Cancer prevention. Cervical pap smear, incredibly important. We talked about skin cancer can be part of the process of patients who are on medications. And of course, colonoscopy. DEXA scan, really important. We talked about PPD. We talked about other blood tests, and one of the other blood tests that can be done, IGRA, in addition to interferon gold. But again, we realize that especially anti-TNFs, TB can be part of this process. Smoking status, depression check, we talked about all of that. So again, you'll have this, be able to refer to this at your convenience. All right, we talked about this before. IBD patients treated with immunosuppression, increased risk of developing non-melanemic skin cancer. Females with IBD on immunosuppression, 6 times higher risk of abnormal pap smears. Incredibly important. All right, our next interactive question. Are you ready? I'm ready. Would you recommend an anti-TNF to a TB patient treated for a month? So let's talk about what anti-TNF means. Anti-TNF means anti-tumor necrosis factor. Anti-tumor necrosis factor. And we had all seen just a little bit of time ago that the anti-TNFs can exacerbate TB. Can exacerbate TB. But this is a TB patient treated for a month. Here's what we need to do. Here's what we need to do. We need to assemble the team. Team approach. Primary provider. You are probably that primary provider. Infectious disease specialist and gastroenterologist. And here's the discussion that would usually be undertaken. The risks and benefits of an anti-TNF as opposed to thinking about something like surgery. You would have to have that discussion in the team and the discussion with the patient as well. But a patient who's already been treated for a month as opposed to a patient who's just been treated for a week, probably on much better ground to get an anti-TNF. And let's move on. I've got another one for you. Would you use an anti-TNF in a patient with a remote history of breast cancer? Are you scratching your head trying to figure that one out? Let's talk about that. And again, it's a very parallel situation that we talked about before. Here we go. Here's the answer. Assemble a team. Now, remember that when we're assembling the team, a patient input is incredibly important. But I'm talking here about remote history of breast cancer. Those patients who I've encountered with a remote history, more likely than not, when I've had the encounter with the oncologist and their primary care provider, we usually are able to go ahead. This is as opposed to a recent history of breast cancer. Let's talk about this. Your elderly patient on an anti-TNF is bringing in their grandchild for an MMR. Is there any concern? Is there any concern? Okay, let me give you a hint. Is MMR a live virus? I can hear the wall shaking. And there we go. It contains live virus. So there's a potential risk, even though it's not mentioned in the PDR, there can be a potential risk. So have somebody else take that kid in for the MMR, because again, there's a slight risk, and why take that risk? Why do anti-TNFs lose effectiveness? We had talked about that previously, but let's see what you recollect. You ready? Here we go. Antibody formation. And remember, that's why we give the antimetabolites in combination with the anti-TNFs to prevent that from happening or to slow down that process. And there we go. Anti-TNF and anti-metabolite. So when should we switch anti-TNFs? Sometimes that's a problem. And let me help you with that process. When we should switch is we want to make sure the gastroenterologist will get a serum level of the anti-TNF. We want to make sure that that's adequate. But if there's no response, we switch to another product. All right, interactive question for all of you. Ready? Can anti-TNFs be given intermittently? Here's the answer. Antibodies form. So the general, the rule of thumb here is absolutely not. It should not be given intermittently. It has to be given on a regular schedule basis. How about this one? Should we, or could we ever stop anti-TNFs? And the answer at this point is no, because we don't want to have those antibodies develop. Poor prognostic features, it's a typical kind of thing that you might expect. Young individual, severe perianal disease, need for steroids, extensive disease. That's a poor prognostic feature, and it's a great indication to be extremely aggressive. Poor prognostic feature in ulcerative colitis, young age, non-smoker anemia, extensive disease. And I'm going to give you a great example story in my practice that I think is going to be particularly useful for you. It was a young individual. He was in his early 30s and non-smoker, significant anemia. He was like 24 hematocrit when he came to see me. Extensive disease, probably the worst disease that I'd ever seen. I recommended immediately coming into the hospital for medications at that time. Refused because at the same time that this young man had ulcerative colitis, his son was in Children's Hospital here in Hartford being treated with Crohn's disease. So we got the genetics part of that. To make a very long story short, after he ended up in other hospitals with a lengthy course of all kinds of medicines, suddenly he was discharged from one of the other hospitals and within a day needed an emergency colectomy. So that again reflects on something that we talked about before, that ulcerative colitis, the cure for ulcerative colitis is the colectomy. I love puppies. Case 1. John R. is a 56-year-old lawyer with a 40-year history of Crohn's disease. 10 years ago, he had an ilio-right colectomy. So the ileum was resected. Part of the right colon was resected despite recent therapy. He's had an additional segment of ileum removed and now feels well. Pathology shows a clear margin. What should we do? Should we wait and see? Colonoscopy, medicines, or send him far away? And the answer, in my estimation, is as follows. And again, there can be variation in the theme, and I'm going to tell you about the variation. I would do medications. I would do anti-TNFs or some of the alternative medicines out there to prevent this from happening. But I want to just share this little bit with you, which is so very important, that another doctor may not feel the same way. They may feel that they want to do serial colonoscopies. They may want to do CAT scans or MRIs. They may want to do stool testing to just see what happens over a period of time. And I'll tell you why. Because it's been 10 years interval from one episode to the other. So one of my colleagues may just say, let's just watch and wait. I would particularly be aggressive with medications, but some of my colleagues may want to watch and wait. So what are the risk factors for recurrence? Smokers, we talked about that before, penetrating disease, and previous surgeries, and that is my concern. Let's continue. So we've got all kinds of medicines out there for Crohn's disease. Here are some of them. There are all kinds of medicines now for ulcerative colitis. Every month it seems that there's something new. We know that there have been very few comparative studies, so we're really going to a certain degree by the seat of our pants. And let's move on to extraintestinal manifestations, and we can zoom through this pretty quickly to show you. And let's show you a few things. So more in Crohn's disease than ulcerative colitis. 50% of all IBD patients have it. and 30% can have it prior to IBD diagnosis. So let's talk about it, what they are. It can be arthritis, a hypercoagulable state, osteoporosis, anxiety, depression, gallstone disease and Crohn's disease, kidney stones, and what do you think this is? Erythema nodosum. Erythema nodosum again. This area that is ulcerated, pyoderma gangrenosum, ankylosing spondylitis, uveitis, iritis, all can be manifestations, these extraintestinal manifestations. So the important part that you need to know in clinical practice, if they happen to have these things when they already have a diagnosis of inflammatory bowel disease, that is great, and you know how it fits together. If they have these things before the diagnosis, then you know to concentrate on their symptomatology. Are they developing things that you think might be Crohn's disease or ulcerative colitis? Let's now move on to Jeff. This is going to be very, very helpful for you. Jeff, 37-year-old, ulcerative colitis for 20 years, despite having been on maximum doses of Imuran and adalimumab. So Imuran is the name for an antimetabolite. Adalimumab is a medication, anti-TNF. Still has 6 bloody bowel movements a day, and physical is unremarkable. He's got an elevated white count, slightly elevated, shift to the left, anemia, MCV, reflects anemia, CRP, not too bad, and a colonoscopy is moderate pancolitis. So the symptoms, why maybe the symptoms continuing? And we're going to get right back to this in just a moment. So let's go back to the story. 37-year-old, ulcerative colitis for 20 years, despite having been on maximum doses of these medicines, 6 bowel movements a day, and elevated white count, anemia, CRP is not bad, colonoscopy is moderate pancolitis. So let's talk about each individual item here. Why may the symptoms be continuing? Could this patient have Clostridium difficile? Absolutely. One of the important takeaways from today is 20% of patients, 20% and even more patients with ulcerative colitis exacerbations have Clostridium difficile. Remember that fact. So anytime you have an exacerbation of that patient with ulcerative colitis, get Clostridium difficile. Make sure that that is obtained. NSAID use, well, we talked about that before. NSAIDs can certainly exacerbate ulcerative colitis. Compliance, absolutely. We all know what the issues are with compliance for patients, and we always have to go back to that. Worsening of ulcerative colitis, could that be? Absolutely. All are correct. Let's talk about this, tectonic changes with biosimilars. One of the most important things, and you may have been actually encountering this with some of your other patients as well, is we weren't quite sure when biosimilars came out a few years ago whether they would be as effective as the original products, the anti-TNFs. It turns out that they are indeed as effective. So we know we don't need to be concerned about that anymore. So wrapping this up and talking about personalized treatment, how do we figure out what patient is going to get what medication? Until we have more data, until we have the genetics, until we have the microbiome and things that we can't even begin to imagine at this point, we have to go by things like this: disease severity, location, extent, activity. And then we look at the efficacy and safety of certain medications. And we have to also look at cost and insurance, adherence and patient that also both of these fit together, patient preferences and adherence. Again, especially if patients have a preference for oral versus other ways of delivering the medication. Women of childbearing age, prior biologic use, all play a role. And ultimately, how does this all come together? Irritable bowel syndrome can be distinguished from inflammatory bowel disease by the lack of alarm symptoms or alarm signs: rectal bleeding, anemia, weight loss, and fevers. One of the most important things that I told you today. Ulcerative colitis is curable. Crohn's disease is treatable. Ulcerative colitis, when we have surgery, the disease is removed. Crohn's disease is treatable, meaning that 40% plus can have recurrence of their illness. Remember what we talked about with ulcerative colitis. One of the roles that I'd like to see that you play is having that discussion with the gastroenterologist with regard to medications. What is the end point for this patient? To continue medicine after medicine when they're not making progress, or to inevitably have that surgery done and get to the point of cure with ulcerative colitis? Remember that smoking is a significant independent risk factor in inflammatory bowel disease. We want to make sure that your patients are appropriately vaccinated. And last but not least, delayed diagnosis of inflammatory bowel disease is directly related to a worse prognosis. I have been delighted to present this to you today. And Ms. Schmidt, any further thoughts, any further questions that I can answer?
I took like 4 pages of copious notes. This was so great. The things that really stand out to me as a primary care clinician, first of all, I had no idea that anti-TNFs you could not stop them. Like once we put a patient on them, they're on them for life, and we're not doing intermittent. Okay, that's good to know. With the newer biologics, can those be stopped, or do you just switch from one?
We have to continue. We have to continue. It's all continuous.
Okay. We are not doing enough cancer screening in primary care with any of our patients who are on therapies that may affect the immune system.
Right. And that's the purpose of my discussion here today. So it goes beyond gastroenterology, because some of these products are also used in other areas as well. So now we know to go back, and that's why I gave you that checklist that hopefully all of your colleagues are going to now be using for any patients on anti-TNF, so we can be ahead of the curve.
That checklist was so great. I may just want that slide by itself to put in as a handout for everybody, because it was beautiful. The other thing we are really missing the mark on, particularly in adult medicine, is ongoing vaccinations. Patients just, not only is there resistance, there's not time, we don't have anything in the office, and it's just what you said, we kind of shirk it off to the specialist, and so somebody's got to be vaccinating these patients. They're at higher risk for catching all of these illnesses. So I underlined cancer screening, vaccination, and assemble a team. Yeah. The systemic inflammation is also profound to me, that many of these people, particularly if they're diagnosed in their 60s, are going to be coming in with kind of a cluster of symptoms. The key of anxiety and depression makes me wonder, because I treat primarily diabetic patients, which, by the way, we're now screening for osteoporosis too. We had no idea that sulfonylureas and insulin could affect bone density, but now we're doing that. But now
you taught me something. Thank you very much. I appreciate
you're welcome. It's in the new guidelines is to do screening. You're welcome. But the component that inflammation must play in anxiety and depression, and for so long we've really kind of asked those, just buck up or do lifestyle changes. When we look at these chronic illnesses, it may be more than just having a chronic illness itself, if there are higher rates of anxiety and depression in these patients. So wildly fascinating. Inflammation in the entire body, brain to skin. Nice. Any parting words? I mean, I'm still a little bit scared of IBD, but now
the parting words is what I said before. You're not out there alone. You work with your gastroenterologist, and that's part of the when I go around the country and around the world, is I say team. Team with the folks out there. And sometimes making that telephone call as opposed to doing the text makes a big difference. So going back to the old system, and developing that relationship makes a big difference in some of these patients who are particularly sick. And that's what I recommend.
I love that. I recommended the other day with a very complex patient that they find two different specialists in the same health system so they could, communicate with each other. And one of the other physicians I worked with is like, oh, that's so cute. It's so old fashioned. It doesn't work that way anymore. But there used to be a day where we would do that. So I hope we get back to that. I love the idea of just making a telephone call or reaching out to someone personally and saying, just, what do you think?
Absolutely, because there's always stuff that one question may lead to the other, and there's also stuff below the surface. So we can be talking about a patient, and then you get a question, which is going to be much easier in a telephone conversation than in texting, because it's easier to just talk than to text. And you get that additional question. Oh, I never thought about that before. Wow.
Yeah, no, I think that's a really good point. The only other thing that stuck with me that I was going to ask about is the psychosocial component of all this, not only when patients choose treatment and what that is, are some of these medications complicated in not only cost, but them accessing and living their life, and of the disease itself. Like, do people come to you like defeated? How,
Yeah, you don't want that. You don't want that to happen. If they're coming defeated, that means somebody has let them down along the line, and that's part of why I teach that we don't want that ever to happen to patients. We want to give them a hopeful attitude about the future, and that's why I started out with that slide about stuff from the Middle Ages, because again, we have so many new medications out there. It's not like it was before where there were just, a handful of medications. There are literally dozens of medicines out there that we can provide to the patients. And again, the research is ongoing. We're hardly where we even need to be with this. So there's tremendous opportunity for patients to be optimistic about the future based on all the medicines that are out there and all the new knowledge that we have.
I love that. It's a beautiful place to end. Dr. Buch, thank you so much for taking the time to join us today and imparting your wisdom. You're a fantastic teacher.
Thank you so much.
Thank you. Tips and resources are excellent to our audience. Be sure to check out npace.org for all things NPACE. We will be loading the podcast, of course, on Apple and Spotify, but it's also going to be on our YouTube. And then for CE components, you'll have to find us at learn.npace.org. We are an ANCC accredited provider of continuing education. There will be pharmacology credit also for part 2 of this. But thank you so much for being here. A big shout out to Genentech as well, again, for grant funding to help us provide this. And Dr. Buch, thank you again for being here. We hope to hear from you again soon.
Looking forward.